Good evening, everyone. I warmly welcome you all for another session of PeMSAA evening talk. So today's talk will be conducted by Dr. Thilak Thoradeniya, a consultant neurosurgeon from Teaching Hospital Kurunagala. He's one of my alumnus and he passed out in 1991. So without taking much time, I will hand over to Dr. Thilak Thoradeniya to talk on head injury and its management.
Okay, thank you, Kaushika. Good evening to everyone. Today, our topic is right. I think you all can see. Okay, Kaushika, can you see it?
Yes, your screen can be seen, sir. Yes.
Yeah, that's good. And first, I'll thank to all PeMSAA team and Kaushika and all organizing this event and inviting me to do this small lecture, right? So today I am not going to talk too much of head injuries, especially the critical care management in the ICU and how you are going to monitor the ICP and what's the effect of mannitol, how we are going to do surgery and all. It's a little complicated. So I mainly look into the basic management that you can do in your basic general surgical ward or peripheral units. So, so it is going to be a practical session like thing, and we'll start with very small stuff. So starting with this one, so this is a bald-headed man. So when you look into this picture, and we'll look into this one carefully, and we'll see what we can learn from this small picture, right? So when you check on this one, if somebody asks what is head, simply definition, what definition? So I would say head is an anatomical part sitting on a neck, very simple, right? So then when you are talking about the head injuries, so we need to address all small injuries on the head, as well as very complicated injuries that can happen inside the brain. So when you check on this one, so this head, we can divide in mainly two parts. One is a face and as well as the head. And always we can't forget our neighbor. What is our neighbor is the neck. So when you are talking about the head, so you should never forget the neck. So that is one principle. So whenever you come across with the head injury patient, just exclude the neck injuries. That is one principle, right? Then second, we just forget the head injury, the neck injuries this moment, and we'll just look into the face. Later we'll go into the head, right? The face, mainly you have a soft tissue component as well as a bony component, and you can't forget the eye, nose, and the mouth, right? So first, just to elaborate on this one, this is a bony skeleton. So we all know this one, very simple, right? So we can divide this. This area is the facial skeleton and the skull. And if you can divide the skull again two parts, this is a vault and the base, right? So then when you're talking about the soft tissue of the face, so many times you will come across with contusions, lacerations, hematomas. So main problem with the soft tissue of the face is to have some amount of bleeding and management of a difficult management of upper airway. Sometimes you can get the airway obstructions. So And other thing, in the long run, they can have the scarring, cosmetic problem and all. So managing a soft tissue in the face is little difficult. So to concentrate on that, first we'll go into the bony structures and the fractures happening on the bony structures, and we'll talk on the soft tissue component when you're talking about the fractures of the facial bone. Right. So this picture, so this we are going to talk about the maxilla. Right. So you will say this whole area is the maxilla simply. So the fracture of the maxilla, the presentation, usually they will have a big hematoma over the facial. The patient will come with the swelling of the face. Sometimes they will have a bleeding from the nose and a lot of proposed bleeding from the mouth and the larynx, because of mainly the fractures going on the maxilla can create a small vessel damage inside the face. So these patients, mainly the problem is the airway management, and they will have a lot of edema and the pain. So usually these facial bone fractures, initially, as usual, we should go on the basic management, airway, breathing, and circulation, the resuscitation of the patients. So many occasions, you will not have that much of big problem in the facial injuries. Usually the hematomas, bleeding and all, very, very minimal. Sometimes you can come across with a patient with a lot of nasal bleeding and a lot of oral and the pharyngeal bleeding. So many occasions with the simple pressure of the nose, controlling the blood pressure and all might work. And sometimes you may have to put a nasal pack to control the bleeding. And some occasion you will have very, very profuse bleeding. Patient can have hypotension and confusion, the low Gcs and hypoxia and all sort of problem due to the hypovolemia with massive bleeding. So these patients, the management is little difficult, but so if you can secure the airway and if you can pack the nose and the throat and a whole pack, sometimes you can get some amount of control of a bleeding. Right? These the main problem of these maxillary fractures are the bleeding. And next, there are different classification coming from facial, the maxillary fractures. So when you're talking about these fractures, there are 3 types. And so simply the Leaport 1 fracture, that's a name, it's just separate the maxilla from the alveolar part. It's the most simple type of fracture. So then type 2 fractures. So this is a type 2 fractures. This is a little complicated one compared to the type 1 fractures. On a type 2 fractures, the maxilla is separated from the zygomatic and arch and the flow of the orbit. And a type 3 fracture is the worst one, which is basically separation of a whole facial skeleton from the skull. So this facial, the maxillary fractures, initial resuscitation is the main one, and fixation of fractures is not a real urgent. So you can do it in a semi-urgent or after about 1 or 2 weeks time. Usually these are done by the OMF team, not by the neurosurgeon or a general surgeon. So that's a little bit about the maxillary fractures. Then we'll have a little look on the mandible. So mandible fractures, usually these are not really common, but sometimes you will come across with the mandibular fractures. So commonest place to have mandibular fractures is ramus and angle of a mandible. Sometimes you can get a fractures at the condyle and sometimes separation of a symphysis. So usually these mandibular fractures, they present with the pain, swelling of the fracture site, and sometimes they can have a troublesome bleeding on inside the mouth, intraoral bleeding. So if you check on these patients inside the oral cavity, you won't find out a big laceration, but there will be some amount of oozing coming up from a hematoma side. So those patients, control of bleeding is little difficult because you are not going to find any active the spurter like thing to suture. So if you come across with that kind of patient, best thing is to pack the area with the adrenaline gauze or whatever the stuff and secure the airway. And after when they are the stable, so you can go with the different kind of fixation technique. So it is also not a urgent one, but the worst one of the mandibular fractures is sometime they can get the body over the ramus, the fractures on both sides. So when you get the both side fractures, the main problem is they develop a very big hematoma over the soft tissues. And when the mandible, this part is moving, tongue is not stable. So tongue can tend to fall down and obstruct the upper airway. That is the main problem of the mandibular fractures. So with the unstable segment of anterior part, that is very, very rare. But if you come across with that kind of problem, initial stage, you can put a airway and see whether you can control the tongue and the fall of the upper airway. But if it is failing, you may have to intubate. But this kind of cases very, very rare to see. Otherwise, other mandibular fractures are not very, very life-threatening. This is again some other picture. So today I thought to go in with the pictures without big the description. So this picture everyone is very, very familiar. So this is orbit. So we'll talk about the little bit about the orbital fractures. This one I think we need to be little careful about the eye injuries and the orbital fractures, because not like the mouth injuries, nasal injuries, the eye injuries are very, very critical because vision is very important per a person. So tiny mistake can leave a big deficit on a patient. So I think you need to be very careful when patient coming with the swelling, hematoma, some laceration over the orbit. So when you're talking about the soft tissues around the orbit, so these are mainly due to the direct traumas of the orbital ridge and these areas, and you will have a hematomas, lacerations, contusions, and some amount of bleeding. And so those cases, tiny things you can control with suturing, wound, the management, antibiotic can only settle. But the issue is if you're having lid lacerations, big hematomas, and all is little critical in a long run, because if you have a lid laceration or upper lid or lower lid, if you don't manage it correctly or if you don't suture it correctly, in a long run they develop a fibrosis and scarring. Then they will have a problem of fine close of eye. So that is a big problem. So if you come across with a patient with the lid injuries, best thing is to clean the area, then get some hemostasis with padding and all. Then you better to get an expert opinion from the eye unit. So they will do the proper suturing. Then when you are going to the bony fractures and the bony injuries of the orbit, we need to talk about the three parts. One is the orbit, the ridge, this area, and then you have an orbital cavity and the apex, because this is the pyramid shape structure. So mainly this ridge fractures is a cosmetically important. So if you have the problem, that also you can do the fracture management little later once you manage the soft tissue component. But when you are going in, so it has a four wall, the roof and the base and the lateral wall, the medial wall. Base is mainly the roof of the maxillary sinus, and the roof mainly by the frontal base covering this area. These two bones are very, very thin. And lateral wall is fairly thick structure. And the medial wall is also very, very thin. This is the most thinnest part of a orbital cavity in the medial wall compared to the roof and the base. But mind you, the medial wall is supported by the different bony septae coming from the ethmoid sinuses, ethmoid cell in the medial side. So it is basically reinforced. So the structure of the orbit, the lateral wall is bony-wise very strong, roof fairly all right, base fairly all right. Even though the medial wall is weak, it is reinforced by the bony septa of the ethmoid sinuses. So the injuries of the orbital capillary is mainly not due to the direct traumas. It is mainly due to the indirect forces. Just imagine if somebody is punch on your eye, the growth is very, very hard structure, it will go in. So when it is going, you will have a fracture, blowout fracture either in the roof or the base mainly. But lateral wall and the medial wall fractures are not that common. So why we are talking about the roof fractures and the base fractures is, it is very clinically very, very important. Sometimes you can miss these fractures and can have a problem in the future. So when you're talking about these roof fractures and the wall fractures, there are two types of fractures. One is a open door fracture and the closed door fractures. The open door fracture is simply once you pull this globe in, because of pressure, the bone wall will open up, right? Then once you relieve the pressure, orbit will come back, but the fracture site won't close up. So those are the open door fracture. It's just like a open door. But when you're talking about the closed door fracture, mechanism is little different. So in same way, the globe will go in, you will have fracture here, bone pieces will open up. Once you relieve the pressure, when the globe is coming out, the fracture site will close down. So that is like closing the door. So this the closed door fractures is little complicated. Why? The open door fractures, sometimes these the superior oblique muscle, recti muscle can herniate or go through the fracture site. But if it is open, there's a space to move the soft tissues, whatever these muscles, and in and out. But imagine if it is a closed door fracture, sometime these muscle can trap either in between these two bone segments. Then you will have a problem of movement of eye. So in the roof fractures, you can have a superior rectus or the superior oblique muscle entrapment. And an inferior wall also, same thing can happen because the wall is very thin. It is just opening the maxillary sinus here, lower down, and closed door fractures, same mechanism, same incident, same the problem. So these inferior oblique and the rectus can trap on the closed door fractures in the orbital form. So these two things you need to remember. So when you have a patient coming with the eye injuries, they can have a big hematoma right there this way, and they will not be able to open the eye nicely. But better to open the eye with little pressure without hurting the patient and see how the eye movements. If they have a problem of eye movement with direct blow, there can be this kind of problem, or there can be some nerve injuries. So the initial presentation, if you are in the casualty department, if you are checking this eye, it's better to mention this one and attend it early. So you can release this one either the roof or a base fractures. And other problem is next, these are mainly the orbital cavity fractures, and then you can have a problem in the apex. The orbital apex, main problem is if there's any fracture segment going and compressing over the optic nerve, it is going to be a neurosurgical emergency. So these patients, So if they complain blind, if they can't see nicely, and if you suspect big fractures, you need to do the CT scan and check the orbital cavity and see whether there's any obstruction to the apex or the nerve or bony fragment going and hitting on the nerve. You can appreciate that on a CT if you're familiar with the CT scan. If you find out that there's any compression over the optic nerve, it is a surgical emergency, neurosurgical emergency. You need to relieve it. So basically, eye injuries, if you know all these tiny things, I think that is more than enough. And when you come across with this kind of eye injury, next thing is to just check the eye, clean the eye nicely with this normal saline. And if you suspect any bad injuries, better to put some local antibiotic eye ointment and then close the eyelid. If there's any laceration over the eyelid, better not to suture it. Just pack with some small gauze, or you can use a Vaseline gauze to cover the wound and put eye pad and secure the eye. So then you can refer them to the eye team to get the management. So better not to intervene too much. So that is something about the eye injuries. So this picture. So these small hematoma here over the conjunctiva, the post-traumatic. So why I'm putting this one is this little clinical significant. This one, so you can see the edges of the hematoma, posteriorly as well as anteriorly, and it is pinkish color, right? So this is a conjunctival hemorrhage. So the conjunctival hemorrhages, you can get the posterior edge, and it's a little pinkish. So if you have a conjunctival hemorrhage, it is due to the direct flow, right? So then just look at this picture. So compared to these two hematomas, this is very big one, it's odd, but when you compare to these pictures, this one is little bluish compared to this one, and you can get the posterior edge. So if you ask this patient to turn this way in a live, so you won't get the posterior edge. So that's mean the bleeding coming from little backward, little posteriorly, tracking the blood deep to the conjunctiva. So that is subconjunctival hemorrhage. So when you examine the eye on a patient, so if you this kind of injury, the conjunctival hemorrhage, it is not that serious, but if you see this kind of injury, that alarms that there may be some deep fractures on the orbital cavity. So if you get this kind of eye, just check the pupil is fully dilated, probably due to the local injuries, and you can see this side is he's looking at this way, but this is the movement is probably the restrictor. So there may be some nerve injuries, or as we said, there may be some muscle entrapment by the roof or the base, and that sort of problem. So if you have this kind of injury, so you need to document it and get the opinion from relevant unit, and you can see the hematoma coming here. So this is little thing about the facial injuries. Then we are moving to, I don't want to talk too much on the facial injuries. So I like to now change into the topic toward the head. Kaushika, any problem from facial part?
No, sir. So far, the students don't have any questions.
Yeah.
We can continue with the head injury part.
Yeah, so I don't think there's too much to talk about the facial injuries. That part is more than enough. Is it, Kaushika?
Yes, that should be enough. Yes.
Right. So then we'll go into the head. So when you're talking about the head injuries, just see the word head injuries, the brain injuries. So head injuries and brain injuries, they're a little subtle change. So if somebody says it's head injury, meaning is little different like the brain injuries. So for me, if I say head injuries, it is all included. Like, so the scalp and the periosteum, then you are going to the bone, dura, so that part, as well as the intracranial component, that is mainly the neural element, brain proper. So the injuries on whole part. So if you are talking about the brain injuries, you should only talk about the injuries to the brain. So this one also will talk little about all these parts. So when you're talking about the soft tissue component, the scalp. So as in other places, so you are getting same problem in the trauma situation. So you can get the cut, laceration, contusions, hematoma formation, burns, so all sort of things. But when you're comparing the scalp and the other part of skin injuries differences, so scalp having very big blood supply compared to the other part, and it is very tough structure lying over the very hard surface, that is skull. So when you are going on to the scalp, so other places you get the proper nicely cut lacerations, abrasion and all, but the scalp, many times you should check very carefully the scalp injuries. It's like the sharp edges cut. You won't see the ragged edges cut many occasions. So simple reason is, so you have a bone here, very tough structure, and skin is tightly stretched over and tough structure. If somebody sit on this one with the blunt object, you get the tear, but the edges are very just looking like a cut, not like a ragged end, not like a abrasion. So many occasions when you come across with the skin scalp injuries, the laceration and cut, you won't differentiate nicely because the edges are more or less clean. And the skin, the scalp laceration, when you're checking on the scalp laceration, some laceration, the skin edges are very close. Some laceration, skin edges are little wide apart. So there's two different things. This is clinically important. So just imagine this: you have a periosteum, and the gallia is a next layer superficial to that. That is very tough structure. So if you have a cut just above the gallia up to the skin, the cut edges won't go apart because the gallia will hold the scalp together. So if you cut the gallia, because of a tension of scalp, that will give away. So when you're looking at the scalp laceration, if it is a very close one, that indicate the laceration is not going through the gallia. So if you see the wide laceration, that means the laceration is, or the cut is going through the gallia. So these two observation is very important, I think. So if you come across with the patient with the simple the laceration without that big gap, so it is mainly the superficial injury. If it is a wound is very gaping and wide about the edges, that means this is going deeper. That means the laceration, the force applied to this area is much more bigger than the other case. So if you have a bigger laceration, wider gap, always you need to be little careful. So this is a little thing about the scalp laceration. And then contusions and the hematomas, main problem is the pain and the swelling. Many will self-limit. Many injuries like contusion and hematomas are self-limiting. The next problem of the scalp laceration is, as we said earlier, this scalp is very vascular. So even 5-10 centimeter scalp laceration, can cause a lot of bleeding. So sometimes these patients come to you to the A&E department having about 10 centimeter laceration. Blood pressure may be 100, little low side, and patient is little drowsy, and people will be little panic. So there may be big head injuries, so they will do all sort of thing without attending to the scalp laceration. So the first thing is, if you have a big scalp laceration, control the bleeding. So that is the first thing. So just apart with the airway breathing circulation like this, the resuscitation, just control the bleeding. Controlling the bleeding of a scalp laceration is not that difficult like in other places, because now you have a very hard structure here, that is the skull, and over that you have a scalp. So if you put a lot of thick layer of a gauze and put a lot of pressure, then you can compress the scalp just over the bone, and that compression will stop the bleeding. So that is one maneuver you can do in a A&E department. So if you have a patient with big laceration, if you can't switch it quickly, just put a good pressure bandage over the scalp laceration. So that will all settle out your many problems. So next, any other main important point on the scalp laceration? I don't think so. Mainly the bleeding, and then the hematomas. Hematomas of the scalp. Young patients not that common, but pediatric population, so neonate and all, you can get the caput. Then subperiosteal hematomas and subgaleal hematomas. So these are mainly with the time that will settle. But there's two different things: the subgaleal hematomas and the pericranial, that is under the periosteum. So if you have a hematoma under the periosteum, it is localized to the relevant bone, because the periosteum is attached to the sutures. If it is above the periosteum, it is subgaleal one, it is mainly the diffuse. So this little thing about the scalp injuries, right? Then we'll go into the skull. So this is a little interesting area when you think. So already we talked a little about the face, mandible, maxilla, and the orbit, tiny things. Now we concentrate on a skull. So the bony fractures happening to the skull, any clinical sign, symptom, what we can do about the fractures of the skull. So I would like to separate the skull mainly in the two parts. One is the vault, that area, right? Then this one I will say the base. So skull base, right? This is a vault, this is a skull base. So a skull base, so there are three parts simply. So the part, this is just in the frontal area, is a frontal base. Very simple. Take it very easy, very simple. This is a frontal base. So then you get the middle fossa, middle base. This is male temporal area, and then this is a posterior fossa, posterior base. So the problem coming with the frontal base, it's little different to the middle base, and the posterior fossa problems are completely different. And the vault injuries and the management is completely different. So just remember this picture and just try to remember all tiny points, and in a later life you can just try to work on this one. So when you're talking about the fractures of the vault, simple one is the linear fractures. Linear fractures will give us some idea about the force of an injury. So if there's a fracture, that's mean some significant force has been applied to the skull. So linear fracture, many times it will go unnoticed unless if patient has some other complication. But if you notice a simple linear fracture on a skull, so when you're going to look into that carefully. So if you have a tiny fracture here, linear fracture, probably it is not that significant, right? If you have a fracture going here, what you call the pterion, right? If you have a fracture going here, the place called pterion is really a significant, I feel, because you have middle meningeal vessel coming here. If the linear fracture is going on that way, so there may be some chance of damage in the middle meningeal arteries. So those patients can develop extradural hemorrhages after some time. So if you have a patient coming to the A&E department, Gcs 50, no other significant problem other than the headache, you simply did the X-ray. So you notice a small linear fracture going here. So it has to be little careful on that patient. So that is one significant point of a linear fracture. And so you can see the suture here, and you have a sagittal suture coming here. You can see this one, this picture, and the lamboid transverse sutures coming here. So if you have a fracture going on this place across the sagittal sinus or across this suture, that also a little significant because the sagittal sinus is just under the sagittal suture, and you have a transverse sinus and sigmoid sinus coming in. So if you have fracture going in across these sutures, so there can be some damage happening to the deep-seated sinus. So that can create a problem. Even on the presentation, patient is all right. Sometimes they can have a problem. The developing hematomas is sometimes not common in sinuses injuries, but they can have a sinus thrombosis after some time. So be careful if a patient coming with the linear fracture going across the sagittal sinus or a transverse sinus. Then what are the fractures? Next one is a depressed fractures. So nowadays depressed fractures are many common due to the road traffic accident. So you will notice a patient coming with the depressed fracture. The basic clinical examination, when you feel the scalp or the trauma site, you will see the depression or dent like that. So those patients you can suspect the depressed fractures, and simple X-ray will show you some depression. But if you can do the CT scan, you can clearly see the depressed fractures on the scalp. The point of a depressed fracture is depressed fractures. Many of the depressed fractures you need to address surgically. So what are the indications for surgery in a depressed fractures? One is if you have a very depressed, big depressed fracture coming on a forehead, if it is disturbing and it is ugly, so cosmetic purpose, you need to elevate the fracture. That is one indication. Remember that. So if a patient is having depressed fracture, cosmetically significant, you need to elevate. That is one indication. And second one, if it is a compound fracture, so if the fracture is opening to the outside, if there's a wound, so you can't wait. You have to elevate it. So that is a second indication for elevation of a depressed fracture. And third one, so you do the CT, see a bone view, I'll show you later. So if you see some bony fragment or the spike or bony pieces just impinging on the brain parenchyma or jutting into the brain parenchyma, you can't wait. You have to elevate the fracture and repair the fracture depression. So that is third indication. And fourth indication, so if a patient is having some depression fracture here, having some neurological deficit, or if a patient having seizures or some other neurological impairment, that means the depression is the fractures, the depressed fracture segment is causing some disturbances to the flocculent or functional area to the brain. So those situations you need to elevate the fracture. And last one, I would say, if you notice some CSF leak, so or if there's some boogie mass, fluctuant, this thing, so if you suspect CSF leak, then you need to elevate it. Probably those patients can have a dural tears. So those are the few indications for elevation of depressed fractures. So I think you all need to remember this. And next, if we have a depressed fracture coming across the sagittal sinus, sagittal suture, or across the transverse sinus somewhere there, across the sutures. Now you need to be little careful because elevating on these fractures over the suture lines, just where the sinuses line is a little tricky. So sometimes if you are going to go and elevate these fractures over the sagittal sinus or the transverse sinus, you may damage the sinus and can have a big bleeding. So the elevation of fractures, depressed fractures over the sinuses is controversial. Sometimes surgeon may decide not to elevate the fractures, right? So those are the little thing about the fractures of the bolt. Then when you are coming to the pediatric population, pediatric patient, sometimes you may misdiagnose the hematoma for a fracture. So sometimes the child can come with a small hematoma over the forehead or the scalp. And when you feel, you will feel the depression, just like a dip on the center of the hematoma. But once you do the X-rays or the imaging, you won't find the fracture. So that is one misleading thing. Sometimes you may come across with that kind of problem. That is because of the center of the hematoma is not that strong. The blood will push away when you put the finger at the center of the hematoma. So you will feel it like a depressed fracture. And children, especially the growing children below 6 months, 8 months with the simple depressed fracture, especially do not need any elevation because sometime when they are growing up, all these tiny fractures would heal off because normal modulation of the fractures. So that is not a problem in a pediatric population, especially the neonates and all. Next, about the fractures of the skull. In the pediatric population, there's a fracture called growing fractures. Right? This is especially happening in the pediatric, the children. Again, the name is growing fracture. So what happens is the pediatric neonates skull is growing, and imagine if you have a fracture here somewhere in the skull and dura got damage. So the arachnoid and brain can herniate with if the fracture defect is fairly big, arachnoid and the brain can herniate. And top over that, you will have a skin. So in the long run, because of a repeated pulsation of a brain parenchyma and the arachnoid will disturb the healing of a bone. So after some time, tiny fracture can have a big hole. So that is called growing fractures, especially in the children. Just to know it, it's interesting. Right? So then those are the main thing you need to know about the vault fractures. So if you have that kind of little knowledge about the vault fractures, that is more than enough. Then we'll go and look into the frontal base. So this area, there are different problems coming. So the frontal base, the middle base, and the posterior fossa base. The frontal base, so you have a lot of air sinuses here. Frontal air sinus, ethmoid, and then sphenoid sinus coming a little backward. And many occasions you will have fractures going across the frontal base. The problem with the frontal base fractures, even that is not directly open into the outside, it is open into the air sinuses. So basically, if you have the sinuses fractures, skull base fractures at the base, opening into the air sinus, you should consider it as a compound fractures. So because they can have a infection going on these sinuses into the brain. So this is a little different, one point. And then these patients can have a CSF leak. If you have a fairly big sinus fracture or the frontal air sinus, ethmoid air sinus, they can have a CSF kind of and the CSF mixed stuff can come out from the nose. And these patients, I earlier said, they can have a subconjunctival hemorrhage and periorbital hematoma. That's what you call raccoon eyes. Right? They can have the anosmia. So that kind of problem. So if a patient coming with facial fractures, frontal bone fractures, having some CSF leak, subconjunctival is highly suspicion of the frontal base fractures. Management of a frontal base fractures mainly the conservative. So if the patient is having CSF leak, usually many of the patient within 2-3 weeks time, spontaneously that will heal. But some patient you will have continuous CSF leak. So those patients, sometime later you may have to repair the dural defect. So other than the frontal base fracture, there's nothing significant. So basically the conservative management or the medical management, you don't need to do the surgical intervention or patient with the frontal base fractures. Then when you are coming to the middle fossa, temporal area, so you can have fractures on the temporal base. So maybe mainly the linear fractures, whatever this. So there are some important clinical finding on the middle fossa or the temporal base fractures, because you have a facial nerve coming here and you have a external auditory meatus. So if a patient is having a middle fossa fracture, there may be some significant clinical finding. One is sometimes they can have a facial palsy, and sometimes they can have a hematoma coming on the posterior side of a orbit. That is called battle sign. And if you check the ear canal, if the ear drum is the intact, you will see the hematoma under the drum. That is called hemotympanium, just under the tympanic membrane. If a tympanic membrane is got damaged, you will see some blood coming here. And if the fracture is going to the temporal segment, damage in the dura, sometimes you may see CSF coming through the ear canal. So if the patient is having some CSF leak, some hematoma, or just posterior to the ear, that is called the battle sign, facial nerve palsy, that is alarming sign. So you can suspect the middle fossa fractures. So middle fossa fractures also basically you can manage without any surgical intervention. And the posterior fossa is comparatively different to these three areas, vault, frontal base, and the middle base, because now the posterior fossa, this whole area is just under the skull, and this area is totally covered with all these neck muscles, trapezius, sternocleidomastoid coming this way, some other deep muscle coming here. So this area well covered. So if a patient coming with some fractures over the posterior fossa, posterior base, this area, that means that patient has had some severe, that very forceful injury to this area. So these patients can have significant brain damage. So if a patient coming with injuries, fractures on the posterior fossa is very significant, because they can have significant injuries intracranially, right? Right. So this is a little thing about the fractures of the skull. So this is just to show you the multiple facial injuries, road traffic accident patients. So you can see the fractures going on, all these orbital fractures, roof fractures, depressed fractures, everything's there. So you can see the depressed fracture coming here, the ridge fractures, some fractures going on there. So all these, see the default type 3 like fracture going here, right? So mandibular fracture coming here, right? So ramus fractures here, symphysis, diastasis or symphysis here. So this is a massive injury. So these patients, so even you can see the fractures and fracture coming here in zygomatic arch. So management of this patient. So basically the first, as basic rule, the resuscitation, airway, breathing, circulation, and sort of thing. and secure their life. Then whatever the relevant investigation, exclude the significant brain injuries, then exclude the neck injuries, chest and abdomen of the patient is stable. So you can go and fix all these fractures in a semi-urgent or 3-4 weeks time or 1 or 2 weeks time. So the initial resultation is the main stop. Yes, Kaushika. So I am going to move into the brain injuries now. If you have any problem or question of skull fractures, we can discuss now.
One of the students have asked whether depressed skull fracture whether depressed skull fracture is an emergency.
Yeah, that's what I said. So depressed skull fractures, if it is a compound one, yes, it is an emergency, right? If the patient is having any neurological deficit, like weakness of the arm, or if the patient coming with the seizures, yes, that is an emergency. So other cases, so simple depressed fracture, if you are going to do that one as for the cosmosis process, so you can do it a semi-urgent, like.
Right.
Okay.
Right. Okay.
So now we'll move into the brain injuries. Right. So this picture. So Kaushika, this lecture all going with the pictures. I thought not to put a lot of the word sentences and all.
Yes, that's good.
So late evening, everyone is in full stomach and all, sleepy and all. So reading a lot of stuff going to be a little hard, I thought. So this picture, I think everyone knows. Very, very popular, the common picture. I don't think there's nothing to discuss on this one. But just to refresh the stuff, I would like to talk about some herniation syndrome. So just imagine, so why you are doing all these the monitoring principle of monitoring when you are pick up the emergency situation of the patient, that sort of thing we can learn from this simple picture. That's why I'm going to discuss on this picture. So just imagine the simple scenario. So somebody is walking in the road. So, and his best friend come and hit on in the head with the big ball. So he suddenly collapses. And then after 4-5 minutes, he just wake up, just stand up and come back to normal life. So transient loss of consciousness. So that is concussion. So people say concussion. So somebody has had some sort of severe the blow to the head. So patient can lose his consciousness transiently. So after 4-5 minutes, they can come back to normal. So there is concussion. And so just imagine this type of things happen. So patient recovers. There's nothing big. But because of an initial injury, imagine there's a small blood vessel tear inside the brain, right? So now with the small hematoma, the bleeder, there will be a little hematoma forming here because of an initial insult. He had some sort of consciousness, probably loss of consciousness, regain. Now it's going on, but still the hematoma is expanding inside. So what will happen when the hematoma is going up? So when the hematoma is growing up, so one principle in the brain, so whole brain is covered with the skull. So that is a tough structure. So it can't expand. And inside you have a brain. So now imagine the hematoma is slowly expanding. So when the hematoma is slowly expanding, it needs some room. So how we are going to get its room? It will push the brain out, right? So when it is pushing the brain out, so there's some pressure is building up inside the brain. So to normalize the brain, the pressure inside the brain, what you can push out from the brain is the fluid stuff. So two things in the brain, the fluid form. One is a CSF. So some of the CSF will push out, and then the one is blood. So some of the blood will push out. So, and then try to maintain the intracranial pressure in a normal level. But after some time, if this hematoma is continue to go up, so that mechanism will fail. On that, when this is happening, you will notice patient may complain of a headache, severe headache, worsening headache. Sometimes you'll have some vomiting, right? His GCS will be little deteriorating. So this is one alarming sign. So all head injury patient, we are putting a big chart uh, and monitoring GCS and the BP, pulse, respiratory, other sort of thing. So why you are monitoring this one? Just relate to this one. So initially patient will have some headache, vomiting, little bit of change of a GCS. So that means something going inside, like the hematoma growing up. So initial stage, they will compensate, pushing some blood out, pushing some CSF out, and maintain the pressure inside the intracalvarian compartment, or simply the intracranial compartment. So imagine now we are not still diagnosed, so we are just monitoring. Hematoma is going up. Now pressure is building up inside. Some of the CSF has and the blood has been expelled out to maintain the pressure inside, but still hematoma is going up. What happens when the hematoma is going up? Pressure will slowly build up. When what will happen when the pressure goes up? So brain is going to have some ischemia. The blood supplies go down because the intracranial pressure is little high compared to the systemic blood pressure. So brain won't get enough blood. So in a simple manner, so if we have some problem, we'll call to our friend and say we'll ask for some help. So same thing happened here. So brain now getting little blood, still ischemic. So he is not happy. So he will call to his friend. What is friend? The heart. He will say, sir, hey, hello, look at me. I am not getting enough blood. Give me some blood, right? So then what will happen is the heart will identify brain is not getting enough blood. He will pump more blood with little high pressure, right? So now ICP is little high, so heart will pump little but in a high pressure, right? To compensate the ICP. So now your monitoring chart, blood pressure will go up. Right now, brain is little happy now. He is getting some amount of that, right? Then what will happen? So when the pressure is going up, the peripheral part, so other areas, they will notice the blood pressure is high on other side. So those guys will say to heart, hey, guy, look at me. Now we are getting enough blood, too much blood. Why? We don't need that much, right? So then heart is going to go down, right? So then they will get bradycardia, right? So one sign, the vomiting, headache, high blood pressure, bradycardia. That means the patient who had a concussion, right, now developing some sign. So if they have this kind of problem, so in a situation in the surgical ward, if the patient is now repeated vomiting, GCS is going down, blood pressure is coming up, some amount of bradycardia, little thing. So that's alarming sign. So these patients now you can't wait. You need to go for a ideal situation, the CT scan. But in a peripheries, what you can do is you need to urgently transfer these patients to whatever the place, they have the CTs and other facilities. So that is alarming signs. Then, so when these things happen, still hematoma is expanding. Then what will happen? So the compensation is now over. So then what happen is brain which will push away to give some room for the expanding hematoma. So there are different herniation coming in these cases. One is if the hematoma is coming here, so this one, this is a fals, and the cingulate girdles can shift to other side. So when you're reading on these CT scans, you may come across subfalcine herniation, right? This cingulate girdle is just pushing outside, right? So this one, so you have anterior cerebral artery coming here. So in a CT, you will see this artery is just pushing this way. So this case, not all the cases, sometimes when this cingulate girdle is pushing this way, there can be some compression over the anterior cerebral. So those patients can develop the weakness over the lower limb area. Not all case, these some clinical scenario. Sometimes patient can have some neurological problem. There's lower limb weakness because of a subfalcine herniation and compression over the anterior cerebral artery. One thing, and then other thing here, the main problem. So when the hematoma is going up, so this area, normal side temporal lobe, you call this area uncus, right? So this is a tentorium, normal side. So you have a third nerve here. So it is coming from the brainstem going inside to cameras side. It is running somewhere there, right? Just remember the simple anatomy. Now hematoma is expanding. Still you are monitoring, very good observer, not attending the patient, right? So now when the hematoma is going up, so one way this can push this way up. Another thing, this thing, the uncus can herniate at the edge of the tent and go down this way. So now I told you the third nerve is here. So this one can go and hit the third nerve. So other physical sign. Now, if the uncus go and hit on the third nerve, so you will have a changes on a pupil. So they get the pupillar dilatation. So ipsilateral pupillar dilatation. That's how you are going to explain the ipsilateral pupillar dilatation. So the uncle herniation, this one, when hit on the third nerve. So you get the ipsilateral herniation. So that is very, very significant. So your patient, some amount of a little hypertension, maybe little bradycardia, and some pupil problem coming, alarming sign. So very critical situation. So these patients you need to attend urgently. So imagine still you are not attending, just observing the patient. So whole brain can shift this way, right? When the pressure is going up this way very high, sometimes this one also can herniate to the tent edge, other side, the uncus. So there is a other side uncle herniation also can go and damage the third nerve. So next step is a contralateral third nerve paralysis. So dilatation of other side third nerve. Next, the worst scenario. So if disease goes down, then whole brain can shift lower down, making the problem of the vital center. So your blood pressure is very high now, you're having bradycardia, now you have respiratory centers and all vital centers. So they can have irregular respiration when this is going lower down, and sometimes whole thing can herniate lower down. So if you have that kind of problem, the brain is all herniated through this one and having some respiratory problem. So in that stage, if you identify the patient and do whatever the surgeries, recovery is very, very poor, right? So our aim is to identify them very early and address the problem, right? So I think this is a simple way I talk about this later, because that where receptors, how it is, the bradycardia comes and all. But if you can remember this simple the theories like this, so it might help in the future, right? So that is the one type of brain herniation. So there are other different type of brain herniation, like this. Now I will tell you some. Hello. Now I told you that earlier, the other picture. Some problem going on. Some problem going on. Give me 1 second. I'll Sorry, I had a little technical problem. Let's go back to again the little lecture. So this one, I talk about the brain herniation on this one, this side. So then the brain can herniate along this line, along this plane. Right, this one. So now, when the patient is building on this way, you have the skull base here. So if the patient is building up this way, the whole brain can herniate on that way down, right? So that is called the sagittal, or this direction transfer sagittal herniation. So this one, the pitch is not clear here. So you have a pituitary gland here, stalk here. So when the brain is herniating this way down, there may be some stretch, the pressure over the pituitary stalk. So then they can have electrolyte imbalances, hypophysis imbalance, ADH secretion problems, and all. So they can have diabetes insipidus and that sort of sodium problem. So that's how you explain that kind of problem. And other thing, so basilar artery is coming here. So it is lying here, and there's tiny arteries going into the brain. So when the brain is herniating this way down, there can be some damages to these tiny arteries. Then you can get the small hematomas inside the brainstem. So those are called diurate hemorrhages. Diurate hemorrhages, just for interest. Yeah, just remember this one. So there can be some type of herniation in this direction as well. Then we'll go back to this picture again. Another herniation is now, I talk about the hematoma or the mass effect developing on this side. So sometimes you can have a hematoma in mass developing on a infratentorial compartment. That is very critical. Compared to this, the supratentorial compartment, infratentorial compartment is very small. So you can't accommodate much of a blood clot or whatever the mass, and all these vital centers are very close. So in a posterior fossa, the masses or the hematomas, whatever mass effect, won't follow this basic rule on our hypertension, bradycardia, this Cushing reflexes and all. It is sometimes they will suddenly collapse because this area is very critical. So management of a hematoma or the mass effect in this area is completely different to this one. So just to have some idea. Yes, Kaushika. So that is little thing about the little herniations. Any problem on that part?
Few questions they have raised. They have asked, what are the late signs of increasing ICP? Are bradycardia and high BP late signs?
So usually bradycardia, hypertension, and the respiratory failure is the latest sign. So sometimes some patient can have so all these things are in the injuries. So they can have the little hypertension developing early, but when they develop a hypertension, bradycardia, and respiratory failure means the whole brain is herniated across the tentorium, and brain stem is affected. So probably the early signs is the hypertension. So if the patient is having hypertension, bradycardia, and the irregular respiration is the worst side. So you can't give a cutoff level, but if the patient is having, we'll say, low GCS, some pupil changes, hypertension, maybe the early signs.
Right.
Okay.
Right. And they have asked, I think you answered this question as well. Considering herniation, is there a particular pattern of herniation like subfalcine which occur first? I think that depends on the location of the lesion, isn't it?
Yeah. So this one, if the hematoma is coming here, so this area will herniate first. Right? So usually our usual pattern won't follow that routine. So if the hematoma is in the temporal lobe, they will have this third nerve problem and this the weakness and all early. So in a neurosurgical ward, if a patient is having temporal hematoma, temporal area, the problem, we are very, very careful because this can herniate early and they can have problem early. But here you have enough the room to accommodate that part. So science is a little late. Okay.
Right. Then they have asked regarding herniation. Again, they have asked how can you describe the electrolyte imbalance that is created during brain herniation? I think that you already explained with the stretch of the pituitary stalk. There can be balances in sodium. Yes. Then there was, does the compression of oculomotor nerve can cause paralysis of extraocular muscles? Can patient present with diplopia?
Oh, a little tricky questions. The issue is this one, checking diplopia and all, little difficult in this situation. So
In the trauma situation, yes.
The trauma situation, because now if the patient is having the third nerve compression, this one of a problem, probably you won't be able to check the ocular motor, but they can have, because the third nerve palsy can have all these problem, eye movement problem. But generally on these patients, if they have a third nerve compression and dilated pupil, I don't think you can check the eye movement. That may be the problem, that many textbooks don't describe that kind of the eye movement or anything on this head injury patient, because maybe it is a little difficult to demonstrate because their Gcs is low, they are not obeying and all that. But technically they can have.
And there were two more questions on fractures. Are growing fractures or simple fractures palpable even in adulthood, and do they persist without healing?
Yes, the growing fractures, usually they will have a bony defect and you may feel the brain pulsation, and that there will be little bulging like in a front annula. And the adults also can have the problem of non-healing. So if there's a big defect or some fibrosis going on, as in other fracture healing, other places, long bone fractures, even in the adults, they can have the non-healing fracture with some defect.
And the other question they have asked is it wrong to take battle signs CSF leak from ear as a posterior skull base fractures? Some books have described them as posterior skull base fractures by dividing base of the skull fractures only as anterior and posterior.
Yeah. So these are the little difficult questions, the classification and all. So different books classify different ways. So I took this as a most easiest way. So people can remember this frontal base, middle base, posterior base. So there's posterior fossa, posterior base fracture also can have this battle signs. I won't say no, because these are the little, so the clear margin, I can't say there are some gray.
There can't be an exact demarcation, but there can be certain overlaps as well, isn't it?
Yeah. So some gray areas there.
It's another question again. What is the difference between concussion and lucid interval?
So very good question. So lucid interval, so that is time period. So concussion, so that is transient loss of consciousness. So if you have some force, the very powerful force happening to the insert into the direct into the brain, there may be some transient disturbances of brain activity. So they lose the consciousness for a temporary period and they recover. but in the lucid interval, so it's like EDH. So initially they lost consciousness and they gain the consciousness, and then when the hematoma is going up, all this herniation can happen, and then later they can lose the consciousness again. That is a lucid interval. So you get the period. I think I'm correct. Okay.
Right, thank you, sir. Yes.
And I forget one other thing. What is lateralizing sign? So many people talk about the lateralizing sign. So that is now when this brain herniation can go on like this, the uncle herniation patient can develop a weakness. So you have a pyramidal tracts coming here, other side pyramidal tracts coming here, the motor tracts, and it's crossed at this level. Right now, when this uncus is herniated, it will compress on this side motor tracts, right? And it will be shown in other side. So they get the contralateral weakness, right? So that is a common sign. So sometimes patient can get the ipsilateral weakness. That is called lateralizing sign. So now imaging, so this is a different kind of scenario happening here. So it is not like a direct pressure over the motor tracts. Now there what will happen is when the uncus hernia is this way, there's some rotatory shift. So brainstem move this way to other side, and this edge can hit over the tent edge. So there will be some disturbances to the motor tracts and this way. So they get the ipsilateral weakness. It's a very rare sign. Sometimes patient can develop the same side weakness. So that's how you explain it. So that's called lateralizing signs. Sometimes very occasion patient with the hematomas on the right side can develop a weakness on the same side. Okay. So shall we move to next?
Yes, we'll move on.
So I thought to discuss a little bit about the CT scan. So just to show you EDH, STH, and have some rough idea about the CT finding. So this is a common picture everyone knows. So what measure in the CT is the density measured by House unit. So this brain, so this whitish stuff is the bone. So high density one will look in a white color, and when the density is cooled down, it's a little blackish. So this is a high density, that is bone. And next, this is the hematoma. Hematoma looks white when it, because the density is a little high. So this is a concave thing. So it is a typical EDH, extradural hemorrhage. So the hematoma is outside the dura. So this one. So this picture is little different. So this one, so this is the skull. So you can see the hematoma coming like this. Right? So that is a subdural hematoma. So this subdural hematoma, some herniation has happened here. So you can see the some amount of midline shift, and this ventricle is being compressed. And other side is little larger. So this side, the CSF is displaced, giving some space to this hematoma. This is subdural hematoma. This is a acute one, so you can see the whitish stuff. That is a density is little high. So when the density is low, you look it dark in color. So this is a chronic subdural. So you can appreciate the difference. So this is acute one. So this is a chronic one. So the two different things. So when this one acute hematomas, this is really hard. You can't take it with a small opening. You have to take a bigger craniotomy and take whole part out, because this is very hard. But the chronic one, this one is the fluid lipid like. So you can put a small burr hole, small here, hole here, and small here, and you can wash it away. Right. So this is intracranial hemorrhage, ICH. So you can see the blood hematoma inside the brain parenchyma. So this is a typical feature of a subarachnoid hemorrhage. So blood is under the arachnoid, so in between pia and arachnoid. So these are the seal vein feature system. So this is this appearance is typical of the subarachnoid hemorrhages. So there's small the hematoma or contusion coming here. So these are the complicated picture. This is a post-traumatic injury. So this one having a lot of injuries. One, these are what you call is a contusion. It is little different to the hematoma. It's a tiny hematoma, it's whitish in color, right? So these are the contusions coming here. And there's a thin layer of a subdural, that subdural hemorrhage. And these are the pneumocapillars, air inside the brain, because it is the color is, it is a air. So this some amount of the contusion, small subdural, and the pneumocapillars. And when you check in this area, so if your eyes are very familiar, you will notice the edematous brain. So just to elaborate, this is a normal CT, just to remember stuff. So when you are looking at this CT, I said if the density is very high, it's look white. So I am telling the very simple way to remember all these things without very high-fi stuff. So this skull is white, so density is high. When the density is high, you look the stuff very white. When the density is low, it's look black. So look, these are the sinuses. So these are color of air. That's how you see that in the CT. So this is a CSF. So there is a color of a CSF. So if you see something similar to this color inside the brain, that is air. So that then you can say it is a pneumocapillus. Okay. Now a little stuff. So this is a frontal base. We have a frontal lobe here. Right, middle base, the temporal lobe here, and the parietal area here. You can see the Sylvian fissure. Right? And these are the ventricles. So ventricles, very easy to remember the parts. So you have a ventricle, so mainly the frontal horns. So these are the part going to the frontal lobe. You call it a frontal horn. So part going to the occipital lobe. You call it a occipital horn. So part going to the temporal lobe. So temporal horns are not visible in a normal CT. And then these are lateral ventricle. You can see the septum pelvis. You have a third ventricle here, right? So this is a fourth ventricle. So trying to know the CT scan. Any problem on that segment, that part? CT scan, I don't want to discuss too much on a CT. I just show the simple appearance. Kaushik, any question coming from student side?
There are few questions, and not on the CTs, but on the previous topics.
Yeah.
If you want, you can discuss this, and then we can.
No problem. We'll answer the
discuss
question.
them at the end of the question, isn't it?
No problem.
Oh,
Yeah, we'll finish that question and go.
yes, yes.
Yes.
So they have asked, what are the indications for intubation in head trauma?
Basically, that is going with the basic resuscitation. Why you are intubating patient is, so many head injury patient main problem is maintain the airway. When the GCS is going down, they can't maintain the airway, upper airway. So if the GCS is less than 8, it is advisable to intubate the patient. patient. And if you suspect a major injury inside, if the patient is heading for a big surgery, better to intubate. And if you think that patient is having chest injuries, abdominal injuries, if you can't maintain the saturation, so you need to intubate. Otherwise, if the patient is having fairly override Gcs above 8, and if they can maintain the upper airway, if their saturation, blood pressure, other parameters are maintained well, it's not really necessary to intubate the patient. And other thing, if you are working in a peripheries, far away, about 50, 60 kilometers away from the general hospital, and you are receiving the patient suspect of having a bad head injury, say GCS is 10, you can't assess him much of facial injuries. So you are going to transfer this patient to some other center, taking about 1 or 2 hours. During that transfer, you are not sure what will happen to the patient. So best thing is to intubate those patients and send to the relevant center, but better to inform those the people, the center, or whatever the on-call surgeon, so they will be ready to accept the patient. So basically, if you can't maintain the upper airway, better to intubate.
And there's another question regarding transfer. When a patient present with head injury to peripheral unit, do we monitor with charts at the center, or do we transfer straight away to the tertiary unit?
That it all depend on initial assessment.
Yes.
So that's why I said the facial injuries, tiny thing, airway management, some jaw injuries, maxillary sinus injuries, eye injuries, and all tiny soft tissue injuries. I just elaborate on this one. So you can assess the patient, see how severe is the injury. If you are suspecting bad facial injuries, if you think that ARV is not going to maintain, so that kind of patient, better to intubate and transfer. Good answer.
Yes. So thing is, if it's a major head injury, you will definitely have to transfer the patient. But if you're suspecting a major injury, it's better to transfer rather than keeping in a peripheral unit until the patient deteriorates.
Yeah. So that is basically the clinical assessment and your judgment.
They have asked whether they have to memorize the head injury observation chart. I don't think you have to memorize the head injury observation chart, but all they have to know about the components in the chart, they have to know, isn't it, sir?
Yeah, don't remember all these charts, even the Gcs and all. So everything is in the chart. My issue is not to memorize in the chart or not to maintain the chart. Pick up the stuff at the earliest possible time. So it is very difficult to remember all these charts and all these theories. That's why I didn't take this very serious lecture and just simply discussing the relevant topic. So people will remember this.
Yes. And then I think we discussed this in the trauma lectures as well. They have asked if there is a major bleeding from the scalp laceration, do we have to manage that, or whether we have to assess the airway and airway breathing and the circulation.
So this is, you should go simultaneously. You can't manage the airway and then attend to the bleeding, or attending the bleeding and then second airway. So it is a teamwork, I think. So A&E department, you are not alone. You have a team. So somebody can attend to the airway, somebody can attend to the other bleeders. So all these things should go together. It is simultaneous. So there's no any hard and fast rule. So finally, what you need to do is stabilize the patient, secure the life. That is the main name. So A, B, C, D, that all these things come, your whatever all this management is to secure the patient life. That is the first thing. So when you are going to do that one, so there's some other components, some many branches. So you can't forget one thing and attend to the other thing. Everything should go together. That's my feeling.
Yes, that's true. Yes, in the A&E, it all happens simultaneously.
Yeah.
So one patient will take care of the airway, one patient will take care of the breathing and the circulation.
Yeah.
So that's how it should go. So you can't attend into one thing and then another. But if you're alone, of course, you can apply some pressure onto the scalp laceration and then control the airway.
Then what you need to do is prioritize the stuff. So if you think that the patient is having massive bleeding, so having hypotension, blood loss and all, so those patients probably their GCS is low, probably they are having some hypoxia and all these due to the hypovolemia. Those patients, the first thing is to control the bleeding rather than going into the airway. So you can judge it. So that is experience and your thinking. So if the patient is having tiny scalp laceration and some facial injuries, if he can't breathe, so no need of attend to the tiny the laceration, just attend to the upper airway. So if you think that patient don't have any doesn't have any big injuries, face and all, having about 15 or 20 centimeter big laceration over the skull, if he's breathing well, even the GCH is 5-6, first you need to attend to the laceration rather than attending to the airway, because now he is anyhow maintain the airway. But main problem is big laceration and bleeding. So you can prioritize your requirement and you can decide it. There's no any hard and fast rule in a clinical scenario, in a board work. So that's happen when you come to the books and all. Okay.
And the other question they have asked, does acute subdural hematoma look convex as well as the one shown in your slides?
Yeah.
I think the classic description is the
yeah. So that is
convex.
a question. So what he says is correct. It is good observation. Right? So classic one is the like this one. So this is not that. So probably this is the old man one. So this one, maybe you can have a, just my inference, you can have a small EDH going here, right? And top over that, you can have a subdural. So that is one explanation. You can see some blood coming here, it's going that way. So sometimes it's continuing this way, and at the same time you can see here. So maybe double pathology. You can have a EDH as well as subdural, both together. So that is one explanation. Oh, otherwise you can have this type of stuff. But mainly it's look like this. Okay.
Then they asked, what are the indications for burr hole?
Burr hole indication. So trauma situation you're asking.
Yes. That's very much necessary for them, but just
no, I think they need to have that answer, because now management is totally different. Nowadays, the CT scan is readily available. Many centers within, if you can transfer the patient within 3-4 hours, they will do CT. Many centers you have a CT. If you have a CT, you can diagnose your pathology, right? So, but in our olden days, we didn't have that facility. So then people went on this, the clinical judgment. So if the patient is having these pupil problems, the weakness and all, the trauma side and all sort of things, then they didn't have any suitable images. Sometimes they only had X-rays, very olden days. Then what they did was they put a 5-bore hole over the skull and just open this burr hole and just check whether there's a hematoma inside or not. If there's no hematoma, they manage it like the medically, or if there's hematoma, they just all connect together and do a bone flap and take out the hematoma. So that is one thing earlier happened. Nowadays, that is not happening. So you have a CT readily available, you can do the CT. And once you do the CT, I say the acute one is stuff, it is rubbery like hematoma, it is not liquefied. So those things with the simple burr hole, tiny hole, you can't take it out. So you need to have a big hole, you need to have a big craniotomy. But in a chronic one, this is liquefied one, right? So then you can put a small burr hole, and this is a fluid, simple fluid, so you can wash it out. So these cases you can put a burr hole. I think got the answer.
Yes. And then they have asked, is lucid interval seen only in epidural hemorrhage?
So it is common in epidural, but I don't think it is only in the epidural. So any other cases, or if the scenario is happening there, so they can have that kind of problem. So that is not only in the epidural. I don't think it is only in the epidural. So other cases also, if the mass effect is going according to the described way, they can have it.
They have asked if, along with head injury, if the patient has spinal cord injury, in that case, is GCS reliable? If so, if not, what are the other ways to assess the patient?
Yeah, very good question. So GCS assessment, so you have all these eye-opening, motor, verbal and all. So if the patient is having, we'll say the neck injuries, so you can't assess motor, right? That is definitely there. So you can, but you can clinically assess the neurological function of upper and lower limb. So you will some cervical injuries. So at the same time, you can talk to the patient. If he's talking well, he's oriented, if his eye opening are normal. So if you can't identify any head, the scalp laceration, hematomas and all, and even their GCS is 15, if their GCS is 15, they will talk consciously without any problems. So then you can see the judge whether it is the head injury or the spinal injury. So issue is sometimes some patient coming with both together. So they will have the head injury as well as a cervical or thoracic spine injury. Then the situation is worst. So then what you need to do is the more important is the life, to save the life. So you need to address the head injury first. At the same time, you need to secure the cervical, whatever the spine, either cervical or lumbar. So you need to secure the cervical spine, you need to secure the lumbar spine and address the head part, brain part, because that is the most serious life-threatening one. So address the life-threatening one, then you can go back to the spine. So that's why initially I said you can't forget your neighbor, the head and the neck. Got the answer? Any clearance? Happy?
I think that should be, yes, I think they got the answer. Then they have asked, are there any lateralizing sign except ipsilateral limb weakness?
So that's why I explained. So that picture, that is it. Right, this one. So I said the uncus can herniate here. So this is some theoretical explanation. Sometimes you may come across, sometimes you may not. So this one, so when it is going this way, there can be compression over the deep side, anterior cerebral, callosal and pericallosal arteries. So these are supplying to the motor cortex in this area. This area is mainly the lower limb. So sometimes patient can have problem on the lower limb. And this one, the lateral sign, the lateralizing sign. So this and that. So there may be some other way of brain shift. So these are the main the ways, but you can have different things. Sometimes you may not be able to explain all this, but these are the main thing. So if you have this kind of rough idea, I think that is adequate. Right? Okay.
Right, sir. We'll move on.
So there are very few slides. So it is going to go over very soon. So this is the question. So I think already we discussed this one. 24-year-old male is admitted to a district hospital following a RTA. He is drowsy with left temporal region laceration and bleeding from left ear. Discuss the management of this patient. So I think this is an open question. So you can answer with some basic, and if you can rationalize your answer, I think that is enough. So there's three things I would highlight on this one. One is the age. This one, 24-year-old male, right? So that means he is a healthy one, right? So he has enough energy to survive. So with this patient need your maximum care, and he is drowsy. So that means either mild or moderate type head injury, not a severe one. Second, this is a district hospital. So the district hospital you have, what are the basic things? You will have some saline, some antibiotics, some suturing material, needle holders, syringes, and you will have some cannulas. Very occasionally, some district hospital has the X-ray facility. So in your center, the district hospital, I don't think you can do anything other than the X-ray in some hospital. So basic resuscitation you can do. And the other thing is the staff. So district hospital, I don't think any district hospital has a consultant. Only the medical officers. So medical officers, they have some limit of managing the patient. So this patient, so the main management is the initial assessment and initial resuscitation. So the airway breathing, whatever this. So I'm not going to elaborate on that one, people know it. So secure his life and then attend to this regional problem. So you can see how the laceration going, how deep it, whether there's some bony fractures, ear injuries, some CSF, and sort of thing. If it is tiny injury, without big bleeding, if the bone was not exposed and all, so you can address the wound, keep some time, reassess. If he's doing well, if he's recovering, if his Gcs come into 15 and all, there's no any urgency to transfer. So if you think the patient is deteriorating, he's saying very bad injury, some skull fractures, so he bleeding from ears, ESF coming. So those are some alarming signs. So those patients, I think you need to transfer. So this is an open question. So you can address those three and answer your question. So management, what I think we have already discussed. And when you are transferring this patient, you all know that we need to give only normal saline, not the dextrose, we all know. And the mannitol, so there are so much of controversies. So basically you can start the normal saline if you are transferring, and he is drowsy, that means he's mild head injury. So if you suspect some neck injuries, stabilize the neck, cannula, some IV fluid, good the dressing or stop the bleeding, that sort of stuff. Then you need to transfer. The patient you can keep in our district hospital and observe. So I think there's no anything other than to discuss this patient, this open patient. So I think my main discussion is over. I will show you some unusual cases. So this just to remember you how important these injuries. So this patient came to Gurunagala. So unsafe pillion rider, bicycle rider without helmet. You can see the soft tissue damage. So all gone. So thankful to the peripheral team. So that's why we are teaching all these. Thankful to the peripheral team. They were their management is good enough to save his life. So what they did was they just keep this flap over there, some saline soap here, and secure the airway, and then they whole wrap this one with the tape and keeping this eye also closed. So they stop the bleeding with the simple compression, and immediately they transfer the patient to our hospital. So mainly the OMF team attended this one. So that patient, people managed to save his life. So simple thing. So the basic management, airway control of bleeding. So that all keep your patient alive. So other people will take care of other parts. So the basic thing is very, very important. So this one, this other patient, it's a very, very unusual injury. This patient had the electrocution. When he's working in his home, he had some electrocuted head. So all scalp was burned off. So there's no any soft tissues. So that's why I said the scalp injury is sometimes very important. And you can see the so many holes in the skull, and this is blackish. So this plastic surgeon has put so many holes inside the skull, because when you have a scalp defect, you can't repair it. So one technique is to put a small hole over the outer plate, opening the diplo. If the diplo is viable, there will be little granulation tissues coming from these places, and after some time, whole area will cover up of granulations. So here you can see some granulation tissues coming from a viable side, but this patient, all this skull was burned off, this dead. This one also dead. So what we did was, we cut out all this part and put a titanium mesh, and plastic surgeon has put a the free flap, this trapezius. So this has got disturbed. So you can see some granulation tissues coming. Right. So this part is necros, but later he put some other flap to this place, and patient he was lucky enough to go home without big problem. So this is some other injury. So unusual injury. So this patient came to Candy years ago. So stabbed to the eye. So what the peripheral unit people did was, they intubated this one. Now the ghost particle is not here. So they have covered this one, stabilized the neck, paralyzed the patient with the intubation sent to the relevant center. Right. So this is the skull X-ray. You can see the knife going in. Right. So this is a CT scan. You can see the knife inside the brain. So what we did was, we did the craniectomy, remove the bone flap, and identified this blade inside the calvarium. Then we slowly took this out without damage in the brain. That patient recovers and went home. So this is one other example of the dedicated work of a peripheral people, the district hospital people, the doctors. So these are the tiny things. So you don't need to worry about the very serious, very complicated stuff. But if you can save their life, maintain their way, if you can stick to the basic thing, control the bleeding, and basic thing will save many patients' lives. Okay. Okay, Kaushika. I think this is the last slides.
Right.
Do you have any more questions?
There are two more questions, not regarding the trauma, but something regarding lumbar puncture.
All right.
We have asked whether we can do lumbar puncture to reduce ICP.
I don't think that is a good idea.
It
So,
will always
yeah.
keep herniation.
So that is from the I think the first year onward, people were talking about
Yes.
the raised ICP and the lumbar punctures. So never do it. Even don't think to do it. So
Yes.
what will happen if the ICP is high, once you put the needle into the spine, CSF will come from down. So the pressure is going to go imbalance. So brain will herniate fast. So sometimes you can have that kind of problem without your knowledge. So sometimes when you put the needle, sometimes when you are taking the CSF out, sometimes patient can get little herniation. If you have that kind of doubt, what you can do is, if that happened accidentally, you can inject some amount of the saline. Say you have taken out the 10 ml of CS, you can inject 10 ml of CS in the same needle. So you can balance the pressure.
Right. That's all questions wise they have, sir. So I don't think they are having any more questions. So shall we wind it up then, sir?
Yeah, okay. I think the lecture is useful you all. So basically, I didn't address the complicated management of neurosurgical patient in the ICU, managing the electrolyte, ICP, the controversies of mannitol, controversies of the hypertonic saline, the cerebral edema, and all sort of things. We just address the basic injuries, basic management that you can do in a peripheral unit.
Yes, I think that's very important for them because when they pass out and go as peripheral doctors, these are the things that they should keep in mind rather than like managing the very minute points like electrolyte imbalances and all those things, because we have specialized units and ICUs for managing the, I mean, very subtle things about head injury, all the carbon dioxides and electrolytes and all those stuff. So I think giving this lecture on the more practical aspect of managing in head injury was very useful for them. And I think they can apply it in their clinical practice as well, rather than I think it will be more useful for most of them, because only few of them will be doing ICU appointments, but others will be handling these things in their day-to-day practice. So it was in the practical aspect was very important. So
okay,
then I would like,
then Kaushik, if they have any other request or any other topic to cover, or if they think that is this lecture is little they need some more clarification and all, so I can do some other lectures in later.
Sure, so thank you very much.
We'll see.
Yes,
okay,
so
then,
once again, I would like to thank Dr. Thoradeniya on behalf of the PeMSAA Council for coming up and doing this valuable lecture despite his busy schedule. Thank you very much, sir.
Okay, thank you.
Thank you, Thoradeniya. I am Dr. Kudagamman here. Thank you very much for taking time. Oh, right. Thank you very much. Okay.
Okay, thank you.
Okay.
Bye.
Bye.